and welcome to Guest Room. This is me, Anjali, here with you. Today we have an interventional cardiologist who has received his medical degree from the University of Florida. He is the former president of SCI and he is a person who is both certified in internal medicine, cardiovascular diseases and interventional cardiology. Let's welcome Dr. Jeffrey Marshal to the show. Hello, Doctor.
Hi, thanks for having me.
Before going to the deeper side of cardiology, first of all, we would like to know more about you.
I'm an interventional cardiologist. That means a doctor that tries to treat blockages in arteries with things like balloons and stents. I live in Atlanta, Georgia, where the Olympics were in 1996, and I've been recently the president of SCI, which is the Society for Cardiovascular Angiography and Intervention. It's a long name for meaning the professional society for doctors that do angioplasty. And because of my job there, I've had the great opportunity to come to your wonderful country and meet a number of your interventional cardiologists here in India, who are some of my very good friends.
What do you mean by coronary intervention?
So coronary intervention is a way that we can treat blockages. So almost everybody, by the time they're 20 years of age, has some form of blockages. When we do an angioplasty, which is blowing up a balloon inside an artery, we crack that artery much the way an earthquake might crack the roof. And so the artery can kind of fall back in on itself and block the blood flow. So we take a little stent, and you can think of it as kind of the spring inside of a pin, of a very fancy spring that you can blow up on a balloon and embed into the artery. So you would push it hard into the ceiling and then take the balloon and wire out so that scaffold stays there and keeps the artery open. That's what a stent is.
Okay. What are the latest advancements in the area of stents?
So stents have been around now for a good while, and we invented stents at first just to keep the roof from caving in kind of thing. But we then learned that the body kind of reacted to the stent. And so the next great iterative change in stents was coating those stents with a medicine to keep the body from growing a scar inside the stent. So you put the stent in, it has medicine on it, it prevents the scar from coming, it prevents the artery from closing, but then over the next couple of years it dissolves and the artery can get its natural function back. So we believe that this is the next great step in stents to treat blockages.
Can you explain PCI?
So PCI is an abbreviation for percutaneous, through the skin instead of through the open chest, coronary, which means the blood vessels that feed the heart, and then the I stands for intervention. So anything that we do on the heart arteries that doctors don't do by kind of cutting your breastbone open would be called a PCI. So that's the big umbrella under which stents and balloons and things like rotablator and other cutters and lasers fall. PCI is the abbreviation for all of those different types of therapies.
To which category of patients do you suggest such kind of a treatment?
So generally it's people that either have a heart attack. So one of the most life-saving things that your interventional cardiologist can do is if you're having a heart attack in the middle of the night, if you get to the hospital quickly, your interventional cardiologist can actually stop the heart attack in its tracks. And that saves lives, and it prolongs lives. It's one of the few things we do in medicine that really makes a great difference in somebody's lives. So people with heart attacks would be the first group of people. But then there are other people that have angina. They maybe it's a grandfather that can't play with his grandkids, or maybe it's a businessman that can't play squash or some sport that he likes. And those patients, when the medicines don't help them, then sometimes these mechanical ways of opening the arteries are the best treatment. And those are the people that end up generally with some kind of PCI.
Can you explain the process of balloon catheter angioplasty?
Yes. So balloon angioplasty was invented by a guy by the name of Andreas Grunzig in 1979. The first procedure was done in Zurich in Switzerland. And the idea was that if you had an artery that, say, was meant to be that big around and it had gotten pinched down and it was impeding the flow of blood to whatever organ, a kidney, a brain, but in our field, mostly the heart, you can pass a small wire through the blockage, and then over that wire you can pass a deflated balloon, put that balloon in there, crack the artery open, take the balloon and the wire out, and hopefully the artery will stay open. That balloon angioplasty is most often also coupled with then putting in a stent so that that artery might have a tendency to close back down. So you take another balloon that has this metal scaffold crimped down on it, you put that in there, you open it up, you then deflate the balloon, it leaves the stent in, and you can pull it out. So the angioplasty and the stent go together much in the way that a hand and a glove might go together in a cricket player.
Can you explain cardiac catheterization and coronary angiogram?
Okay, so cardiac catheterization and angiography are kind of synonymous terms. The ability to see the arteries that feed the heart muscle. You know, the heart's a muscle about as big as your fist, and we have these 3 arteries that sit on top of the heart, but they're tiny. Cardiac cath is when we take a catheter actually up into the chamber of the heart and measure the pressures. The angiography part is where we take a small catheter and put it right in the opening of the artery, and through that catheter we inject some X-ray dye. At the same time, we're taking an X-ray movie. And that X-ray movie can see that dye inside the arteries. And that's how you can see the arteries. There are not many other tests available that can actually see the arteries. So that's what a cardiac cath and a coronary angiogram are.
Can you explain the process of CPR?
Of
How
CPR.
a CPR is done?
Okay, so CPR is cardiopulmonary resuscitation, and it's certainly something that everybody should know, okay? The city of Kochi would be a safer place for you if everybody knew how to do CPR. And in many places, children can't graduate from secondary school unless they learn CPR indeed. So if somebody has a heart attack, what we would call a cardiac arrest, where the heart stops or it goes into an irregular rhythm and it's not pumping blood, people will pass out suddenly and fall to the ground. The heart is not squeezing the blood around the body at that time. Normally the heart squeezes with each heartbeat. With these irregular rhythms, the heart's wiggling kind of like a bag of worms. It's not pushing blood around your body. So if you can immediately get CPR, okay, which is a process where you roll the person on their back, put your hands on their chest, and push down about 1.5 to 2 inches in a rhythmic way, about 15 to 30 times a minute, and I may get the rate wrong here, but if you do that until the authorities can get there in an ambulance and maybe shock the heart back into rhythm, you can save people's lives. So that CPR is a life-giving mechanism for lay people to do.
What do you mean by cardiac arrhythmia?
Cardiac arrhythmia is just an irregular rhythm of the heart. There are 4 chambers in the heart, and the 2 chambers on top and the 2 chambers on the bottom normally work in a 1-to-1 relationship in a very organized way to receive the blood from the lungs and then squeeze it around the body. And that would be called the regular sinus rhythm. There are problems with that electrical system in the heart where the heart can either squeeze too fast or the rhythm from the top chamber of the heart doesn't get to the bottom of the chamber of the heart. So an arrhythmia is simply an altered or diseased coordination of the beating of the heart is kind of what an arrhythmia is.
Can you explain the process of rotational atherectomy?
So rotational atherectomy is another one of those tools that we have in our tool chest under that percutaneous coronary intervention to be able to treat blockages in heart arteries and other arteries. So some of the blockages sometimes get so calcified, the disease process is hardening of the arteries, that's the lay term for it. As the arteries become diseased, calcium gets laid down and these arteries can constrict, but they're like a ring of concrete. So the only way to break that up is to take a device that has some little diamond chips on it, on the front of it, pass a wire again through the blockage, and then spin this special little thing that looks like an orb or a child's top. And on the leading edge of that are some little diamond chips, and they can kind of sand that calcium out of the way to open the artery so that a balloon and a stent can go in. That's what rotational atherectomy is.
What do you mean by STEMI?
So ST segment elevation myocardial infarction, or STEMI, is a type of heart attack. We diagnose heart attacks most easily with just an electrocardiogram. And there are small heart attacks, which are non-ST elevation MI, and there are big heart attacks called STEMIs. So STEMIs are generally the ones that are life-threatening, although any heart attack is life-threatening. These ST segment elevation MIs are the kind that you want to get to the hospital immediately. So for your viewers, if you have a patient that's having a heart attack, what they don't want to do is drive themselves to the hospital. They want to pick up the phone, call an ambulance, and get to the nearest angioplasty-capable hospital so that they can have the heart artery opened. An ST segment elevation MI usually occurs when that artery that feeds the heart muscle, one of these three arteries that are sitting on top of the heart muscle, are totally blocked off. And when they're totally blocked off, the best treatment is to have an angioplasty as fast as humanly possible. So that's what an ST segment elevation MI is.
Can you explain what intra-aortic balloon pump counterpulsation means?
So an intraaortic balloon pump is a fancy name for a device that helps support the blood pressure in patients that have very low blood pressure. So in the STEMI patient we were just talking about, sometimes so much of the heart muscle is damaged that instead of the heart squeezing hard like this, it gets very weak. So if it's getting very weak, it's not pushing the blood out, so the blood pressure drops. And sometimes when we're doing an angioplasty, the blood pressure can drop, and then an intraaortic balloon pump can support the blood pressure for a period of time while an interventional cardiologist could open the artery and the heart can get stronger. So it's kind of a bridge for the heart muscle to get stronger. Now, intraaortic balloon pumps are kind of an old technology, and they can be effective in the short term in certain patients, but there are now some new devices that might be better than that. Different kind of pumping devices.
It is heard that the blockage of artery is due to the plaque formation. How and when does this form?
So plaque formation starts very early, and in westernized countries where we can eat basically whatever we want and not exercise and smoke cigarettes, have diabetes, have high blood pressure, that process actually starts very early. The blood vessels have a kind of a miraculous inner lining. The blood vessel is made out of 3 layers, and the inner layer of the blood vessel actually has the properties that keep us from getting blockages. Blockages may start when we're as young as 2 years of age, when that inner lining becomes damaged just by wear and tear, especially at branch points in arteries. And then over time, as the cholesterol is kind of high, there's kind of an inflammatory process, kind of like if you fall down and skin your hand and get a strawberry on it, you know how it gets kind of all gummy and then it gets real tight? That inflammatory process happens on the inside of our arteries. And over a period of decades, usually 3 or 4 decades, 30 or 40 years, those blockages are growing inside of our arteries, and we don't know it because they haven't narrowed the artery enough to cause a problem. But they're not like rust on the inside of a pipe. They're like little pimples that pop open periodically.
Can you give us a brief on chronic total occlusion?
Yeah, chronic total occlusion is a special kind of blockage in an artery. So it turns out that some people can have a totally blocked artery and not know it, okay? Or they can have a heart attack and recover from it, and that artery stays blocked. So it would be a 100% blocked artery that's actually been there for at least 3 months. Those kind of blockages are particularly difficult to treat with things like angioplasty and stent placement. And actually, people in India, people in Korea, people in Japan have actually highlighted the best treatments for these chronic total occlusions using special kinds of wires and special techniques to open these totally blocked arteries. If an artery is even 99% blocked, it's usually pretty easy to fix, because when we inject the dye to see the artery, even if it's 99% blocked, a little bit of the dye can go through and you can kind of see where you're going. But in a totally blocked artery, you inject the dye, but there's nowhere for it to go, so you don't know what path to make the wire go to get through that blockage so that you're in the right place. And that's one of the things that makes these chronic total occlusions so difficult to treat.
How do you measure the blockage? Is it the number of blockages or is it the depth of a blockage?
Well, you can measure blockages in a lot of ways. There are three main arteries and kind of a fourth artery that's kind of the water main to the heart, much the way there's a water main coming into your house. So we talk about the number of disease, the number of arteries that are actually diseased. Is it 1, 2, or 3, or is it the main one? And then we talk about how severely each artery may be blocked. And most blockages, and we all have them here, maybe we have some 20 and 30% blockages, but when they get to 50% or 70%, that's when we think they're tight enough to be treated. And when they're that tight, they've usually come to the point where they're causing symptoms for our patients.
Can you give us a brief on the multivessel intervention?
Sure. Multivessel coronary intervention is a term used to describe fixing more than one artery at a time simply. So when angioplasty started back in 1979 in Zurich, Switzerland, it was pretty common to treat one artery, and then it was a little more rare to treat two arteries. But nowadays we can treat all three of the main arteries plus that left main artery, the water main to your heart, without having to do open heart surgery. And so multivessel angioplasty is simply a definition or a descriptor of how many arteries you fix at any one time in a patient. And maybe you actually fix one now and then maybe two in a few weeks, but that's multivessel angioplasty.
It is heard that the blockage of arteries causes heart attacks. These arteries supply blood to other vital organs like lungs, eyes, etc. Do they affect the same?
Yes, they do. So arteries are simply blood vessels that carry blood away from the heart. They carry the oxygen-rich blood and the nutrients to our muscles, to our brain, to our kidneys, to our legs. And the process that causes blockages in heart arteries is the same process that causes blockages in necks that cause strokes. So the treatment of these blockages, by and large, is fairly similar. Bigger arteries you have to treat a little bit differently than smaller arteries, and brain arteries different than kidney arteries, but the general principles are pretty much the same. If you have a blocked artery, you want to open it so that blood can flow through. So these blockages are often treated with balloons, balloon angioplasty, or stents, stenting, or with other things like rotablator like we've discussed.
I've heard about 12 leads, 6 leads in the ECG. So what does that exactly mean?
So to do an electrocardiogram, what you do is you put some sticky leads on the chest and on the arms. I'm sure most people have had that done in their doctor's office. And it's an electrical way of like taking a little electrical picture of the heart from many different angles. So you end up with 6 leads on your chest, okay? And then a combination of 6 leads elsewhere between the arms and the legs. And that's a 12-lead electrocardiogram. So the standard one you have in your doctor's office is a 12-lead electrocardiogram. Sometimes when you're in an ambulance or when you're in the cath lab, we don't have all of those leads on. So we can just get by with 6. So it's kind of a slightly different way of getting the electrocardiogram.
Can you give us a brief on incomplete revasculation?
Sure. Incomplete revascularization simply means that you have restored the blood flow to an organ. So in the heart, let's say you have 2 blockages, complete revascularization would mean that you open both of those blockages to give normal blood supply to the heart muscle. Incomplete revascularization is kind of the opposite. It means that, let's say there are 4 blockages and you can only fix 3 of them. So that's the definition of an incomplete revascularization. Patients that get incomplete revascularization are at risk for further problems when they're compared to people that get complete revascularization.
Can you tell us what exactly does complex PCI mean?
So complex PCI is a term used by lots of different people. It doesn't have a specific definition. But it basically means that the angioplasty or the stent placement was not simple. So it could be not simple because it was in a high-risk area. So maybe the main artery to the heart. Or it might not be simple because the patient was about to die. Or it might not be simple because you had to do multiple different vessels and put in multiple different stents. So it's just an adjective for describing how complicated an angioplasty is.
Okay. The next question is kind of personal. What is the greatest or what is the worst nightmare a cardiologist has?
Well, the worst nightmare any doctor has is when they can't treat their patients effectively. And then the worst of those things is when patients die. And so when people are very, very sick and they come in with big heart attacks and you're doing everything you can possibly to save their life and you can't help them, you've done everything you can and they still die, that's certainly a doctor's worst nightmare, because we kind of pledged this oath that what we would do is first do no harm and then do everything we could to prolong a high quality of life. So that's our biggest nightmare.
Okay. Last question of the day. What are your present researches on?
Well, we do a lot of research where I'm currently located. We're actually investigating a stent which is currently available in India and not available in the U.S. It's a stent with some mesh on it that we're trying to see if that will do better in patients with big heart attacks. I've also been involved in a lot of research involving the carotid arteries and arteries that cause stroke. And then we're involved in, our group is involved in a lot of research looking at some new medicines to help people with heart attacks and stroke. And some of our electrical doctors are interested in some new types of pacemakers. So we're involved in a lot of clinical research nowadays, whereas in the past I did a lot of basic bench research.
Thank you, doctor. Thank you for spending your valuable time with us. It was a great time with you.
Well, thank you very much for having me.
So that was Dr. Jeffrey Marshall with us. Until next time, this is me, Anjali, signing off. Take care.